As the presentation on the home-based care pathway makes clear, this is a desirable service for any person with Parkinson's. However, as the presentation also makes clear, its implementation is anything but easy. And I grabbed the opportunity to speak to Dr. Carroll on her thoughts on the availability of this service elsewhere in the country. And there are some interesting clues here as to the pressures on the health service that may assist that introduction. What are your hopes for the rollout elsewhere in the NHS? How much of a shove does this thing need to get adopted by other trusts?
I think we need to tighten it up a bit. Mm-hmm. In terms of the offer. So we've got a nice pack of resources, I think, for helping people understand Parkinson's and what to do about bits and bobs that pop up. I think we've got a nice system for contact that works on the whole, for triggered contacts that people could utilise in other organisations. What we don't do well is identify people who might need a bit more support than just knowledge provision, because of course that is all that some people need, but actually most people need a bit of coaching and a bit of talking through how to utilise the resources and embedding behaviour change, for example. Those things are more tricky, so we could do with investing a bit more thought there. And then in terms of the systems, it's sort of translatable, but what this generates, of course, is a vast amount of data in a service which is not used to dealing with vast amounts of data. So cardiology services, I'm guessing, have numbers, heart rate and blood pressure and things like that. We in Parkinson's, we don't normally deal with numbers, so you have to create a system for dealing with numbers, and that's where the challenge will be for organisations adopting this. And it is, in actual fact, a challenge for us as well. So we're having to invest in data management systems, and hopefully some of those will be translatable as much as they can be to other organisations where they might have a different sort of electronic health record.
The skill of interpreting the PKG watch output, for example, at what level would you have to be before you could really reasonably do that job?
Parkinson's nurses actually working in the trust have undertaken PKG reporting training and have been doing it, and it isn't so difficult that it can't be undertaken by a Parkinson's nurse or Parkinson's specialist practitioner. So yeah, absolutely. And some of the skill is interpreting it, but then setting it within the clinical context of what you know already about the patient, which may or may not be evident in the information that you're provided with. And of course, within home-based care, I'm not looking at it in isolation. I've got half a dozen questionnaires of additional data. So just to give you a simple example, if someone isn't responding to a medication dose, and I can see that on the graph from the watch, the first thing I look for is, are they constipated? So I look at the constipation question, and if there isn't a tick there, then I think about it in a slightly different way. Whereas, of course, if they say they're constipated, then I know to address that first. So it's simple, quite simple things really, but it is utilising the wealth of the data. So the way that I see this going is that over the next 5 to 10, 20 years, let's hope, fingers crossed, we don't have Parkinson's in 20 years, but assuming we do, the way that we manage Parkinson's will be very, very different from how we manage it now. This wristwatch is already Bronze Age in technology terms. In reality, that we could have smartphones, we could have sensors, you could have smart insoles, which measure your gait, whether you get freezing in doorways. We could be looking at the way people interact with their technology as a sort of a cognitive screen. We're doing all sorts of stuff, and I'm sure that over the next 5 to 10 years we will be, and we'll be getting really sensitive signals for how someone is with their Parkinson's and whether they're running into trouble with particular aspects, and that'll be guiding our treatment. And some of that, of course, that amount of data, you can't rely on essentially what's going on between my ears to interpret all these data points. It's got to be done by computer. So we'll have artificial intelligence modelling telling you, yep, Chris, you're stable, no need for any treatment adjustments, or actually, red flag, Chris, we think that this might be happening. And you can go, oh no, that's a load of tosh. I just, had a cold that week or something. you know, and somehow people will be flagged and the information will come back to you to enable you to manage your Parkinson's, and also to inform the healthcare team.
These models that you speak, well, for example, the artificial intelligence stuff, that has to come from somewhere. Is the NIHR going to provide the money?
Yeah.
Is it going to come from commercial sponsors or what?
Or a combination of the two. So we are actually today putting in funding applications to these sorts of joint funding models. There's UKRI, which is an innovation funding stream. NIHR does have an artificial intelligence funding stream. And we've got expertise here at the university that whom we're collaborating with, and also to see, does this actually work in our healthcare system? And a lot of things don't work or won't ever achieve, you know, good full benefit. So I personally don't like anything where people have to pay, patients, consumers have to pay to access that thing. It might be fantastic, it might be the best app for whatever, but if you're having to pay for it, I'm really not that interested in it, because that's not our healthcare system. That's not the system that we have. Our system, I want to be inclusive, and so that people aren't having to pay for these sorts of things. It might be that the organisation has to pay, of course. We pay for the PKGs, but you as a patient don't have to pay for the PKG. Right. So and that has to fit into the company's, the innovators' business model for how these techs are going to be incorporated. And a lot of them expect the patient to pay. That the benefit will be so marvellous, so self-evident and great that the patient will pay. And I'm really not interested in evaluating those, but that's sort of just my personal preference.
So do you encounter suppliers who will only work with a pay-me model and don't want to consort with the NHS?
There are a lot out there. You know, if you want to, there are already quite a few self-help apps, not just for Parkinson's, of course, but a range of health conditions where you pay a subscription to get access to whatever it is. And some of those, a lot of them won't be registered medical devices. Yeah, so you have to take whatever it is they're telling you with a slight pinch of salt. And a lot of these developers will be wanting clinical cohorts to validate, in inverted commas, their algorithm in. So it is a minefield, but the people that do it well, the companies that do it well, there is certainly, you know, a direction of travel, and importantly, the ability to really improve the way that we deliver healthcare through using technology. But it does mean, as a profession, going through a learning curve and changing the way that we think about some of these things, and particularly in the Parkinson's world. So, you know, I said about cardiology before. If you can imagine when the ECG first became a thing, or an echocardiogram, you know, ultrasound scan of the heart. And I remember as a medical student, that was a while ago, but not so long ago. I remember, you know, people saying, what's the point of a stethoscope? We can just do an ultrasound. And it's a bit the same. It's a bit the same with MRI scans of the brain. You know, neurologists from years ago, I'm sure their diagnostic acumen would have been far superior to ours, because they had to be. Whereas now, you know, if there's any doubt about anything, we would just, you know, with somebody through an MRI scanner and see what we can see. And so it's a bit the same with the data. We extract information from patients using our history taking skills or our examination skills. And somehow we have to see how that knowledge maps to this data that we've got. And it won't be an exact map. There'll be areas of overlap. We need to understand where the areas of overlap are, that data you know, maps, where it adds value, where we're seeing things that we're not getting from our history and examination, and also importantly, where that history and examination is still needed, because there is no bit of data that can give you that same level of intelligence. So that's a sort of understanding and a growth that we have to go through, transition as a profession, to really understand how we can use these tools to maximum benefit in the future. Our evaluation was comprehensive and on the whole positive. So I think that has been a big factor in this, and there were lots of complaints about the extent of the evaluation, I have to say. too complicated, Camille. But you know, if you're evaluating what is a complex intervention, you have to, you know, we couldn't have just done the effectiveness without any sort of process measures.
Right.
And we couldn't have just demonstrated feasibility without demonstrating any sort of effectiveness or acceptability. And then, of course, we couldn't just evaluate impact on patients when the people that we need to buy into this are the staff and the organisations. So we also had to evaluate impact on staff and organisations. So it was quite a complicated piece of work, just putting together the evaluation plan and making sure that at least we'd had a nod to each of the really important pieces of the jigsaw to create the whole, which is, on the whole, this works for the organisation, for the staff, for the people with Parkinson's, and for their families. You know, what's not to like?
Landscape, or looking at the potential clients for the pathway service. What would you say is the biggest obstacle for a person to become part of that service?
So when we started it, I thought I want it to be open to everybody, except for people where I think this is really not going to work. And so those were people with cognitive impairment who did not have a care partner, or who were in residential home or care home environment, where, you know, their care or engagement in care might be very dependent on who's on shift that day, you know, for example. So we kept it broad, but actually I think now I would say if you have significant cognitive impairment, then this is not the right way for you to be receiving care. And that's mainly to do with the questionnaires, actually. Because I do need people to tell me the truth, in as much as they tell the truth in clinic, you know, and I'm sure people tell me lots of barefaced lies, but as much as people tell me the truth,
crossed my mind.
as much as people tell me the truth in clinic, I need them to be truthful on the paper. Yeah. So if you've got a problem with falls, tick yes for falls, don't tell me no. We have had some questionnaires back where, you know, nobody has got a single symptom, seriously, not a single symptom. And I thought this isn't, what is this achieving? This isn't achieving anything. And the other aspect of that is, of course, it's burdensome to complete questionnaires. So if somebody isn't able to do them easily themselves, then it's not just a burden for one person, it's a burden for two people in that household. And that's just not fair. Because the care partners then trying to say, you know, how much is this of a problem, or, you know, how much is
they find themselves in the middle of negotiating.
No, exactly. So I think if somebody has cognitive impairment, I don't know that this is the right way to be supporting their care. And actually the upside of this is, because for those that don't have cognitive impairment, where this is a good care pathway and seems to work, that actually frees up clinic space. So before this, I was only able to see people once every 2 years. And that was part of the driver for implementing this at all. And now I'm seeing people on time. So, you know, if I say, actually, I think you're running into difficulty, I'd like to see you in 4 months, I'll get to see people in 4 months, whereas that wouldn't have been possible.
Right.
Years ago. So actually there are benefits across the whole system. So there are benefits for people who can be on the service, but also benefits for people who do need more support, because there's now capacity in the system to give them more support.
That's another interesting topic, which is the changing way that things are diagnosed, and therefore the change in the relationship between us and you.
No, I think that's really, really important. And it is, if I felt guilty about anything, it's that, and it's not an insignificant amount of guilt that I feel, in fact. So I was very heartened to see the soft question responses. How much do you feel listened to? How much do you feel involved in your care? And the fact that all of those improved made me think, okay, so this isn't so terrible, because that is absolutely, really, it is important. And I know that people have bad consultation experiences. I've had them myself, where I've gone to see a doctor and think we weren't really listening to me. So it's not that face-to-face or in-person guarantees that you're going to feel listened to, but you might think that if it's data-based that you won't, and this has shown that it can be data-based and you still can feel listened to. And I think that therapeutic relationship, whatever that is, I don't know that I understand exactly all that is, but it is more than just the face-to-face. It is, you know, being there on the end of an email, or being able to make people feel listened to, and that you've then acted on what you've been told, even if it isn't in a verbal face-to-face interaction.
Emma Edwards, towards the end of her session, said the improvements that we've had were, I don't know, 5 or 7% or something like that. And my reaction was, that's not a lot. Do you have different percents in the NHS from the rest of the world, or why is 7% meaningful?
So, I mean, there's several things. So, one is, you know, the lady that did that bit of work for us, the staff evaluation, the well-being of staff evaluation. She said this is actually, that degree of change is a significant amount of change. It was 10 points, roughly 10%, and you have to remember that this was over COVID. So it wasn't just 10% in normal times. This was an improvement of a significant amount over time when lots of staff were feeling more stressed. And the same for the patients actually as well. You know, the 6 month that we evaluated this over was over COVID, and despite that we had less anxiety and less depression after 6 months on the pathway. So, you know, given the context of when those changes were measured, that makes it even more significant.
Perhaps that's how the number needs to be represented, because, as I say, 10% doesn't get me out of bed in the morning. That's not enough. But if it's expressed in another way.
Yeah. So you're right. It depends who your audience is. So it's part of the long-term plan, i.e. almost mandated by Department of Health, that there will be less follow-ups. We need to reduce clinic footfall, and a lot of those follow-ups are routine. You know, feeding people back blood results that could be done over the phone or by email. You know, why really are we asking people to drive to a clinic visit to be told you're fine? That could have happened. So that's sort of the thinking behind it, which I get. So and I also get that management of long-term conditions wasn't necessarily part of that thinking, but then there's no reason why it can't be part of that thinking. So if I can say to somebody, a manager, with these 100 odd patients, 110 patients that we've had in the pathway for 6 months, that is 200 clinic appointments. And what that actually translated into was 11 clinic appointments. And 8 out of those 11 were done by video. And so only 3 people drove to a clinic appointment rather than 200. So that's the saving.